So it's a great pleasure to have Gina Brown, who Bill and I regard as being the world leader in the imaging of rectal cancer, in particular the MRI for rectal cancer. And I think Bill will agree with me, Bill, that MRI has changed the whole way that we work in total medial rectal excision, which is what you described, and the circumferential resection margin, which is the protective edge of the tumour when you do an operation. But I'd like, Gina, if you could tell us a little bit about the background to MRI, CT, why MRI is so good, and so on.
So without going into too much complexity, the added value of MRI in assessing the pelvis and indeed assessing rectal cancers is that the sequence, the high resolution sequence that we developed for looking at these tumours gives us very detailed information about the anatomy, the tumour itself, and the borders of the tumour against the fat and other tissues. Now, CT is also high resolution, but it doesn't give you that difference in what we call contrast. I suppose it's the same as contrast on television. If you can't see the borders of something so clearly on CT, you can on MRI. So that's why it's so effective at giving us such detailed information.
But just tell us briefly what CT stands for.
Oh, right.
Because when Bill
Yes.
and I, in the
Yes.
80s, when we first met,
Yes.
we didn't have any CT or MRI or ultrasound or anything. Tell us what CT.
Yes.
Bill, would you like to come? When did you?
No, I'm saying that's all we had.
All you had was the finger.
But tell us about CT, where
Yes.
it came from, and what is computerized tomography.
It's computerized tomography, and
What does tomography mean? It's slicing, isn't it?
Slicing,
I
yes.
often say to the patients that actually, if you go to Sainsbury's and say, can I have a few slices of ham, what they do is they put a big piece of ham and you get tomograms of the ham. It's the slices.
Yes.
And what CT is the computerized way of slicing up the body.
That's exactly right.
We can see black and white and shades of grey.
Yes. So a CT scan is actually nowadays is quite a fast process in the sense that the machines that they now have, the camera which is producing the X-ray at very high speed rotates on this gantry, is on top of the couch. You lie on the couch moves through the machine, and during that time the camera is taking thousands and thousands of X-rays, and the very clever bit, which is the computed tomography bit, is it assembles all that information and by various mathematical convolutions produces a two-dimensional X-ray image of every part of you, using the fact that, for example, bone is very dense, so it doesn't allow much X-ray through. Soft tissues, tumours are less dense, and it allows less X-rays through, so you get this difference in grey versus white. So bone comes out as white, and organs and tumours and so on come out as different shades of grey. And what we can also use with CT is intravenous contrast. So an injection is given in the arm, and that circulates around the body, but we take advantage of the fact that it hangs around, for example, in tumour for a certain length of time, so it will look different to normal tissue, where the blood comes in and out very quickly. So that's the sort of thing that technology has done for us, and CT, because it's so fast and produces so many images, you can manipulate the images to get three-dimensional views, so you can look at it in this plane, in that plane, whatever way you want, to give us as much information as possible. The main, I suppose, difference between MRI and CT is that computed tomography is an X-ray method, whereas magnetic resonance imaging doesn't, by definition, it doesn't use any X-rays at all. So there's no radiation dose
You
from an
can
MRI.
actually do an MRI on a pregnant woman, for
Yes.
instance, and we have some beautiful pictures of a young woman with a baby inside at 20 weeks that Bill and I operated on. We might show that. So it is. But why don't we just get rid of CT then? What is CT used for? Was very useful, because as I said, Bill, when
Well, you said fast. Give us the time of a complete body MR compared with a complete CT.
Let's start with the CT
Yeah,
first of all, and see.
I think a CT now we can get through in a sort of minute and a half, 2 minutes. You can go from top to bottom.
You just hold your breath, and then you.
Well, in fact, you can go through from the chest to the bottom of the abdomen. During a breath hold, it's easy. But the thing with that magnetic resonance imaging is we're using a different principle. We're using the magnet to flip water molecules, and it's them relaxing back to the unflipped state that we're waiting for. So we're waiting for the signal to come back from moving water particles in a magnetic field. So it's by definition going to take the time it's going to take. You can't speed that up because you can't change physics. But
how long is it?
For a high,
I think I'd rather stick first of all to CT and then move on, though, because the thing about CT, why do we use? When Bill described TME in the 80s, we didn't have CT at all. Bill and I was a young surgeon. We had no idea that what CT was, didn't use it. But now almost everybody who has a severe abdominal pain or has a cancer of some sort, they have a CT. What does CT give us, Gina?
Oh, well, it
then
gives,
we go on to MRI.
Well, you can imagine it gives us a lot of information from the top of the thorax all the way down through to the bottom of the pelvis. We can see the lungs, the liver, all the abdominal organs. We can indeed see the colon and the rectum, or the bowel, the small bowel, and so it gives us a very good overview of what's going on. So if something sinister is happening, you will see on the CT.
You'll see abnormalities on a liver scan. You'll see abnormalities on a lung scan. And of course, for trauma injuries, you do head injuries, you do CT, you can see bleeding into the brain.
Exactly.
Fractures of the skull, but bleeding into the brain. So that's CT, and we still use CT because it's more readily available and you can do it very quickly. And most people can actually lie on a table, and the gantry, the sort of circular donut shaped thing is not as near to you.
It's not that far. No, it's not that close. No, it's not on top of you.
So now let's go on to MRI scanning, because MRI, magnetic resonance imaging, is totally different in some ways. And Gina, just tell us again. I think it's really since the late 80s and 90s has come into use, and tell us how it works, because it is different, isn't it, how it works?
Yeah, so instead of using X-rays, it uses a very strong magnetic beam, and the principle of it is rather clever in that it exploits the fact that we are all containing mini magnets in the form of water molecules, that when this displaces in a magnet, if you disturb the magnetic field and you pulse it, as it were, the water molecules in our body start to, they flip, and then as you release that pulse, if you bring the magnetic wave back to its normal state, the water molecule gradually tips back up, and because it's moving in a magnetic field, it produces a signal, and that signal can be measured, and the amplitude, the depth of that signal can be measured, and that varies from tissue to tissue. So you can imagine that if you flip it more, there's more variation and you get more differences in the signal coming back, so you get more contrast. And with more contrast, you get more anatomic information. So
and these are really powerful magnets, aren't they? And they're pretty expensive. You can't just have one at home.
No.
Why can't you have one at home?
No, they're very expensive because the magnets, for them to be this powerful, run on supercooled liquid helium and that is, you know, quite difficult to come by at home. And so the supercooled magnets produce these very powerful magnetic fields, and then we use radio frequency waves to disturb those fields in order to jiggle our water molecules.
And what would happen if you went in with your watch on or your earrings on?
You would, well, you wouldn't get that far because our wonderful radiographers always really very stringently check our patients for any metal work and avoid them going into the machine.
So when you say metal work, what we mean is not people who work with metal, it's people who have metal within their body. So if I had a sort of an old gunshot, a bit of
that would be a no-no. But on the other hand, if you've had a hip replacement, then it's non-ferromagnetic nowadays. So any recent surgery, most of the materials that are being manufactured for placement inside humans, as it were, will not interfere with the MRI, and you should be able to work well with it. Even nowadays, some of the modern cardiac pacemakers are friendly for a magnetic, for an MRI. So things have changed a lot.
But there still are a few people on there. If you have a fragment in your eye or something, there's some metal fragment in your eye.
So if you're a metal worker, you know, if you've had metal injury, all those sort of things.
Bullet lodged somewhere that hasn't been removed.
Yeah, those sort of things.
So there are a small number of people who can't have an MRI, but it's very small, luckily.
Yes.
And can you tell us the practicalities? Why can't we just MRI the whole body like we do with CT?
Well, you can actually. You can MRI the whole body. There's a technique called whole body MRI, which allows you to look at the body, but in a certain way. You probably couldn't do the sort of images right now. We couldn't do those kind of high resolution images through the whole body. It would take all day. So that's why we we target the high resolution to certain areas of the body.
So my understanding really was when it started, MRI was really good for backs and spines, and still is very good for knees and hips and with backs. But I think you've taken it to a new level in what we call soft tissue. It's actually very good for looking at bones and joints, wasn't it, MRI initially? And that's what a lot of people still use it for. So could you tell us why is it really good for soft tissues, and what areas in particular? I suppose the pelvis is the obvious one, which is why, for instance, for prostate cancer or ovarian cancer, it's very good in the pelvis. Tell us a bit about that.
Well, I think the key to this is this whole so-called T2 weighted sequence, which is a longer, it takes longer to produce an image that is T2 weighted, because as I was describing earlier, if you flip the water molecule far away, it takes a long time for it to come back, but you get a much greater variety of signals, so you get much more differentiation between the different types of tissue that lie within the pelvis. So that way you're able to distinguish between muscle, between the submucosa, which is the layer in between the bowel edge and the middle, the air. So you get that. You get different signals from tumour itself. You get signal from the fat, all of which allow you to give very precise assessment of what's going on in the body that you couldn't get from CT scanning or any other means for that matter.
If I was a patient, I'd be pretty terrified if somebody said they wanted to flip all my molecules back and forward. What do you think about that? It doesn't sound like a great thing to do. Flipping bits.
I've been fascinated by this because I'm not sure I understood the basics. So it's really good to get this. I mean, the only bit that I understood that made MRI better for me, a cancer surgeon, than CT was that I was told, I think by you, that you'll never be able to tell the difference between the cancer and muscle on a CT.
Correct.
But the images you can produce, particularly with your T2 weighted images that you've described, that you really can see the cancer as a mottled variegated grey, as it were, and muscle slightly different and more homogeneous. So
exactly.
that's the only bit I ever understood.
Bill, just to put it into context, our bowel, in our bowels, we have a lining of the bowel, which is one part, and then every part of the bowel has a muscle layer. And what Bill and Jean are talking about is this, trying to determine what is the normal muscle in the I think most cancers, almost all, will start in the inner layer and
work their way
outwards through the muscle. And what you're saying, Bill, I think is that just for our audience, is that what MRI can do is precisely try and work out what exactly is a muscle or what exactly is tumor, where has it gone to.
Yes.
I think that's really important. And there's no question in my mind or in Bill's mind that MRI has been really useful at supporting Bill's original ideas. And if I just show you this book that actually that Bill and I edited, and Jean has written 2 chapters, you'll see that on the front of the book is actually an MRI scan of a patient of mine that we've put in the front. We were so impressed by the concept of MRI. This is a female patient, and you can see this is the big tumor sitting there, but the scan can give us some very important information, which we'll come back to when we talk about low rectal cancer. But I think that let's go back again, Gina, sorry to harass you, but tell me, if I was a patient going in for an MRI scan, should I be scared? You've probably, hopefully, convinced me that those moving the molecules around doesn't do me any harm. I won't feel that. I won't feel that, will I?
No.
But what would I expect? I go into this MRI scanner, and the Tesla, there's a magnets in there, big magnets and small magnets. Tell us a bit about the Teslas. Not the electric, not the electric car.
No, named after Tesla, the engineer physicist who developed magnetic-based engineering, as it were, and Tesla actually is the number that we use, is the value for the strength of the magnet. So you have a 1.5 Tesla machine or a 3 Tesla machine, and maybe someday there'll be more powerful Tesla machines, but
we've got 14 Tesla for small things.
Yes,
down in Shambhala.
Yes, exactly. So you can go up, and the magnets can become very powerful indeed. But 3 Tesla is safe in humans, and we know this. And I think the thing you experience going into magnetic field is that you don't notice it. But what you do notice when you're in the machine will be the noise, the sort of you hear. It's a very sort of bopping noise that goes, and that will be the radio frequency pulse disturbing the magnetic field.
Oh, I see.
And it's that disturbance that allows the molecules to quiver a bit.
So the noise is actually this magnetic field
being disturbed.
And then you're measuring the movement.
We're measuring the fact that Faraday's law, is it Fleming's law? Please don't quote me on this. But you remember probably from physics at school, is that an object moving in a magnetic field generates a current. You remember that?
Vaguely. Why do you think we're surgeons?
Something moving in a magnetic field produces a signal, and that signal is the thing that we're making use of, and the amplitude of that signal, the power of that signal, relates to the nature of that tissue. So you can really do a lot, you can get a lot of information from making use of the fact that our bodies, and we are largely water-based, as are tumours, but the different proportions of water in various bits of our body give us an idea of what the nature of that material is, and also the way it's all arranged. So as Bill was hinting earlier, when the tumour is present, there's no order to it compared with human anatomy, which is very ordered and layered, whereas tumour is a bit chaotic by its very nature. And so you can tell not just by the fact that of its signal, it's whether it's grey or black, but also its configuration, the fact that it's rather mottled, rather chaotic, and it hasn't got any structure to it.
Yeah, and I think the other thing, of course, which you have developed, and we will talk about that, is you can determine the response to treatment, radiotherapy and chemotherapy, and the changes that happen. And we'll come back to this, and I know Bill and I are very interested in the whole aspect of patients who have chemotherapy and radiotherapy and the tumor disappears, and you can tell that without us having to operate. We'll come back to that, but I think is it possible to have everybody? Some patients of mine are really unhappy to go into this. The MRI technology is still quite claustrophobic, isn't it, Gina? Has that been improved on?
Yeah, you can have open MRI scanners, but I think the main thing with an MRI scanner, if you can tolerate being in an enclosed space, and I think most people can, and they have improved, is that the closer the structure is that's measuring these signals, which is the coil, is to the magnetic field. The closer everything is together, the better the signal. Yeah. And the better the signal. You get to the, yes, exactly. The target. Exactly. The nearer you are to the target, and the smaller the field of view you get, the more the resolution you can produce.
You can define precision, definition.
And so that brings us on to high resolution MRI, which essentially produces an image that's only 16 centimeters square, but is packed with information, and that's what we mean by high resolution. It's a very small field of view, 3 millimeters thick, so it gets to the point where it's almost the same as if a pathologist was looking at the tumour under low power microscopy. We've got sort of sub-millimeter resolution and low power resolution on microscopy. So that's why MRI, when we look at those scans, we have to learn from the pathologists how to interpret them. It's not something you can just wake up and do. You have to spend some time understanding the basis of these scans.
And for those of us who are old-fashioned, 16 centimeters is just slightly bigger than 6 inches.
Yes.
So it's really targeting right, which is why I think MRI is very useful for looking at a knee, for instance, or the pelvis, which is what you focus on. So I think that's why it's really useful. But the other thing which is important, and I remember when we started doing MRI, we thought it would be a great sport not to tell the radiologist where the tumour was. so that we'd say, well, if you can't see the tumour, then... But of course, the real reason for that is and Bill has alluded to it already, is that if it's a small tumour, or it's not small or big, the planning of where you're going to target that is really important. Tell us a bit about that. Well, Bill and I are aware that you can, if you just send somebody for an MRI of the pelvis, it's a big target.
It's a big target, yes. And where do you begin?
You won't get very good definition,
no,
which is why.
That's right.
Yeah. So tell us about that, Gina.
Yeah. So ideally, if a surgeon gives us all the information that they know about the tumour before the patient's being scanned, it gives us the best chance of getting the best scans done for them, for the patient and for the surgeon themselves. So if it's a low tumour, we focus very much on the area around the lower rectum, the anal canal, the sphincter. These are all very complex structures, and it takes time to unravel it all. So you have to take examination in one plane and then in another plane. So in the so-called coronal plane, the sagittal plane, which is sideways on, as well as
so you're
axials.
Going all around.
So we're going around in different directions. And if we didn't know it was there, we would have to just go up and hunt this tumour down, which wastes time. Of course, we would get to the same answer eventually, but it actually is much better to know what you're dealing with and focusing on that area.
And I think we should finish because it's a really fascinating topic, but I had a medical student once, a mature medical student, and he was involved in the development of MRI, and I said to him, where will MRI go? And he said, look at your mobile phone, we would have handheld MRI. Do you think that's a sort of pie in the sky?
I think we have made so many advances just in 20 or 30 years. Who knows what the future may hold for MRI. So yeah, that would be very nice, wouldn't it?
That was very interesting. Fascinating, isn't it?
It is. Would it be a good moment for you just to say what's the difference between your MRI for a rectal tumour and the ones that the other ladies all those years ago dismissed as having no future? What are the things that you do to get better pictures?
Yes. So there are a number of things that we need to get right when getting a good quality scan for the radiologist to look at to get a good answer for the patient. Firstly, the MRI has to be small field of view, which means 16 centimetres or 20 centimetres at most, and high resolution, meaning that the number of pixels on the image has to be quite high. So in other words, imagine a grainy photo versus a high definition photo, or a grainy television versus a high definition television. We want the high definition. So in order to get that high definition, we need to spend a certain amount of time getting the scans. So that means we have to keep measuring, so we keep flipping and keep measuring and using the physics and the computer software to generate those images so that we have the maximum amount of information. So what that means is with a 16 centimetre field of view and 256 pixels in each direction and a 3 millimetre thickness of scans, that altogether gives you a pixel that is only 0.6 millimetres by 0.6 millimetres, and in total the box, the three-dimensional box that for each slice is only 1 millimetre cubed. That's the difference. Now if you make that a big field of view and you lower the resolution, then you are quadrupling you are making the image quality worse by a factor of much more than that, because it's a volume as well. So it's to the power of 3. And that's where you see a noticeable difference in the ability to accurately see the tumour.
So you have to have specialist radiographers who know how to specialist people who actually target, as you say. And I think that sort of gets us to the end of this session, because what really is we're looking at CT to just very quickly assess for big abnormalities, metastases, and we're looking for MRI for precise definition of a targeted area. And sometimes, of course, we will have to do an MRI of the liver as well if there's a suspicion of something going on. But I think that's really fascinating history and practicality, isn't it, Bella, of CT and MRI?
I mean, in rectal cancer, we always have a CT to see that there are no obvious liver secondaries.
Or lung secondaries, and then we have an MRI targeting. That's really Gina, that was fantastic. Thank you very much.
Thank you.
You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. And thank you very much for joining us.